Good morning, everyone. My name is Wipamas Polpakdee. I am from Vistech, Thailand. Today, I would like to present you a topic about TSeizNet, triplet loss empower multiscale CNN for superior EEG seizure detection. Today, we will begin with the introduction about epilepsy and the objectives of this study. And then I will go in detail about data acquisition and the proposed method, TSeizNet, and then experiment before we discuss the results, limitation, and conclude this study. Let us begin. 1 in every 6 people develop epilepsy during their lifetime, make it one of the most common neurological disorder with recurring seizure as leading symptoms. Having recurring seizure affects people's life by limiting their daily functioning and causing early death. That is why quick and accurate diagnosis is very important. Recently, clinical approach typically includes medical history, neurological tests, and EEG recording. EEG recording or EEG or electroencephalography, it records brain wave and allow practitioner to examine brain electrical activity during seizures. However, due to the short and rare natures of seizure, EEG recording often spans several days, and analyzing that amount of data is time-consuming, labor-intensive, and prone to human error. That is why automated seizure detection become a research of the study. For the most of seizure EEG study often include EEG decomposition and feature extraction. But in this work, I introduced TSeizNet, a multi-scale CNN for seizure detection, offering multi-view feature without data decomposition and feature extraction. The second objective is to deal with class imbalance. As I mentioned earlier, that seizure is rare, so most of available dataset is unbalanced. So we integrate triplet loss and cross entropy loss to deal with this problem, to enhance the modelability. And the last objective is to improve practicality. When ambulatory EEG recording is needed, there are patients that report that they feel social anxiety wearing EEG cap in public places because of its complex setup. So we evaluate the adaptability of our model by evaluate model in both full scope EEG and ambulatory EEG. Next is data acquisition. The data set we use is CHB-MIT containing EEG from 23 subjects. And the class ratio between normal and seizure is 1:60. The number of channels selected is 21 channels. Preprocessing include only typical preprocessing step, which is not filtering, low pass filtering, and then the data is segmented into the window of 4 seconds with 25% overlap before we normalize them. So we come to the main proposed method, which is TSeizNet. TSeizNet has 4 main components. The first one is multi-scale convolution block. To reduce the data preprocessing, we implement multi-view learning by implementing multi-scale CNN. It consists of 4 layers of depth-wise convolution. So each filter is dedicated to one EEG channel only. And then the EEG input, I forgot to mention that output from one layer is passed through another. And then the EEG input and output from 4 layers is called 5 EEG representation before it is analyzed in the next step separately. The next step is called temporal convolution. It learns a high-dimensional temporal pattern using just regular convolution. It is 3 layers of correlational layers. And then it will be passed to the next block, which is called mean embedding. To reduce the data dimension, we pass the learned feature through average global pooling and linear layer and sigmoid layer. And at the end of this block, we will get 5 feature vector for 5 EEG representation. And then in the last block, which is classification block, the 5 feature vector is concatenated to form EEG embedding before pass through another linear layer and softmax layer to predict the output. For objective function, TSeizNet has hybrid loss. The first one is cross entropy loss, which is a typical or a standard loss function to optimize classification model. And the second loss is triplet loss to deal with the imbalance problem. Triplet loss ensure the equal contribution from minor class, which is seizure class. It learns distance feature from embedding of triplets of sample and occur positive and negative. It pulls together the embeddings of similar class and push away embeddings from different class. In this study, we have 2 experiments. Experiment 1 is seizure detection. To replicate clinical EEG, we use full scope EEG in seizure detection, and it is in patient-specific manners, and compare with baseline models. And experiment 2, to assess the practicality of our model, we select 4 temporal channels to use in experiment 2, and the setting is similar to experiment 1. Now we will discuss the result. For experiment 1, in table 1, you can see that TSeizNet achieved higher accuracy, F1 score, and AUC, while maintaining comparable sensitivity and specificity. It demonstrates that TSeizNet can detect seizure while minimizing misclassification. Next is for experiment 2. You can see the similar pattern of result, except for there is slight decrease in performance across every metric in every model. The similarity patterns say that, implies that, further demonstrate the ability of TSeizNet in accuracy, F1 score, and AUC. And it also says that the selected 4 temporal channel can capture seizure-related content similar to those from full scope EEG. However, the slight drop of performance in every metric shows a trade-off between using full scope EEG and low density EEG, as it is a trade-off between using the two because full scope EEG has full coverage of all brain regions. And next, I also investigate the impact of triplet loss by perform the seizure detection using TSeizNet with and without triplet loss. The upper one is our proposed method, which has triplet loss. You can see that there is a drop in performance in every metric except for sensitivity. And the lower half is a plot of training loss and validation loss of triplet loss, cross entropy loss, and total loss. It is clear that triplet loss allowed the model to converge later, as it allowed the model to form more complex decision boundaries. The limitation of this study is that the clinical acceptable sensitivity, which is still unmet, which is around 80% sensitivity, and the low density EEG configuration in other low density EEG configuration need to be explored, as well as other deep metric loss functions such as contrastive loss and center loss. To conclude this study, I present the TSeizNet to eliminate the need for additional EEG decomposition as it learned multi-view feature in an end-to-end fashion. It achieved a comparable sensitivity with higher F1 score. And triplet loss can enhance the deep learning model performance in EEG seizure detection task. And low density EEG shows a trade-off between using full scope and low density EEG, as low density EEG has slightly lower performance, but it gives a significant advantage in terms of patient comfort. And future work should focus on alternative deep matrix learning loss and reduce channel EEG configuration. Thank you very much. Here is the reference, and if you have any questions, please feel free to ask.